Hello and welcome everyone to the Sustainable Care Annual Conference 2021. I am Professor Shereen Hussein, a Professor of Health and Social Care Policy at the London School of Hygiene and Tropical Medicine in the UK. I am also one of the co-investigators on the Sustainable Care Programme of Research, leading a research theme on the role and experience of migrant home care workers and the implication of changing immigration policies landscapes. I am delighted to be chairing this session 5B, titled The Evolving Nature of the Formal Care Workforce, as part of Theme 5 of the conference, Sustainable Care at Home, Understanding the Care Mix. We have 3 presentations today, followed by a discussion, and then we will open the floor for some questions and answers. I would like to welcome our first speaker, Dr. Fiona Macdonald, who will present a paper titled Positioning Paid Care Workers in Australia's Disability Support Policy Implications for the Care Mix. Dr. Fiona Macdonald is Vice-Chancellor, Senior Research Fellow in the School of Management and the Centre for People, Organisation and Work in the College of Business and Law at the RMIT University in Melbourne, Australia. For the past 5 years, her primary research focus has been on the workforce implications of social care marketisation and individualisation in Australia, reflecting her broader research interest in the regulation of work on the margins of labour law and in gender equality and decent work. Without any further ado, I would hand to Dr. Fiona Macdonald to start her presentation.
Thank you very much for that welcome, Shereen. Before I commence my presentation, it's our custom at RMIT University to acknowledge the traditional owners of the lands on which we conduct the university business. These are the Woiwurrung and Boonwurrung, people of the Woiwurrung and Boonwurrung language groups of the Eastern Kulin Nations. RMIT University respectfully acknowledges their ancestors and elders past and present. RMIT also acknowledges the traditional custodians and their ancestors of the lands and waters across Australia where we conduct our business. I'm speaking from the land of the Wurundjeri people, and I would like to respectfully acknowledge them as the traditional owners of the land. Could I have slide 2, please? In this presentation, I'm drawing on my research undertaken over the last 4 to 5 years, investigating the workforce consequences of the move to an individualised and marketised disability support system in Australia with the establishment of the National Disability Insurance Scheme, which completed its national rollout in 2020. The NDIS was hailed as a social investment or social insurance scheme. It's a national, non-means tested, publicly funded, personalised or individualised scheme for support for people with permanent and significant disability, and it provides funding for the reasonable and necessary supports a person requires to meet their goals and aspirations for independence and social and economic participation. It is anticipated the scheme will provide funding to some 450,000 people. All NDIS participants, as people eligible for the scheme are referred to, have an individualised support plan. Self-management of funding is promoted by the government and central agency as a goal where this is feasible. In early 2020, 40% of NDIS plan budgets were self-managed by individuals who received direct payments to purchase their own supports, or were plan managed, meaning that they self-manage but with the assistance of a financial manager. So the proportion of plans that are effectively individual payments is very high, and it's growing. The proportion of plans managed by the central agency is declining. Now, a key difference in Australia's system where people self-manage or plan manage their funds compared to many other systems is that it is very, very lightly regulated with very little oversight of the ways in which the money is spent, how it is spent, where it is spent. And that's one significant factor that I think is important in the lessons that we might learn from how this Australian system is rolling out. In regard to the care mix, there's a question of how the introduction of this individualised care and support system has changed the roles and workloads of informal carers. I haven't researched that. And there is emerging evidence and a lot of public commentary suggesting that the NDIS has significantly increased the workload and responsibilities of many informal carers. And there are also indications of some significant inequities in the system, and that it may be increasing existing inequalities, including in access to paid support and care, with implications for informal carers. The NDIS was supposed to shift the care burden away from families and informal carers, and indeed the economic case for the NDIS was built on arguments about potential for an increased labour force participation by informal carers who would be freed up from informal care work. So while there are very many questions about that, my focus today is actually on the paid care and support workforce, which has been the focus of my research. And I argue that this workforce is being increasingly informalised, with paid care workers increasingly finding themselves in informalised employment arrangements and as fashioned and treated as sources of informal unpaid care and support. The main components of my empirical research were a very large number of interviews with paid disability care and support workers, as well as analysis of dozens of policy-related and operational documents relating to the NDIS, many interviews with service providers, digital platform operators, bureaucrats, consumer and care advocates and other policy actors, as well as ongoing monitoring of the online and broader market for disability care and support work, and active engagement as a participant in industry and policy forums. A strength of this research has been in tracking developments and changes as they've occurred. I also believe the Australian case is significant in its relevance to possible futures for individualised social care systems. As I mentioned before, in part because of its highly unregulated nature and the high levels of direct payments, there's very little oversight or accountability for many aspects of the care system, including the paid care workforce. And in that, I think it holds some important lessons for other systems. The second reason is that the NDIS has involved a massive disruption of service provision at a time when digital platforms have moved into personal services markets. And in some of those markets are driving enormous changes in work and employment. The possibility of Uberisation of large segments of the individualised support and care labour market is very real. By Uberisation, I mean a situation where formal regulated employment is no longer the norm for paid disability support and care workers, in funded adult systems in Australia prior to the NDIS. But I have the next. Now, the potential for informalisation of paid care work, degradation of paid employment and paid care workers in so-called affiliations is not a new discovery of mine by any means. Earlier research drawing on comparative studies of European and North American cases has identified outcomes for paid care workers as varying with a number of factors. And critical to how care workers fare in cash for care systems is how they fare in direct employment arrangements, where workers are employees of or contractors to the individuals to whom they provide care and support. Now, surprisingly little research has been undertaken in regard to these, to employees in these types of arrangements or to workers in these types of arrangements. In the English social care system, on which Australia's NDIS designers drew very heavily, there has been very little research. The research that has been undertaken has been mainly small studies, and there's a lot of debate about the interpretation of findings of those studies. With a lot of growth in directly employed care workers in recent years, or so-called personal assistants, as they're called in the UK, in adult social care, there has been more attention to these groups. And one of the few large studies by Woolham and colleagues, including Jill Manthorpe, who is presenting in this session today, was one of the first large studies that hasn't directly relied on employers to access this workforce for research. Now, this study, I don't have time to go into it in any great detail, but overall it found there were high levels of satisfaction, or comparatively high levels of satisfaction of workers in these types of arrangements directly employed by the people they're providing assistance to, or engaged as contractors. But while there was high satisfaction and possibly less turnover, generally the workers were in very informalised. There was a risk of workers being in very informalised work arrangements with some levels of non-compliance with employment standards, and increased risks of lack of oversight or regulatory interest in their work. And the authors concluded that there may be implications for the sustainability of care and its quality. Now, I think what we're likely to see in Australia is this on a much larger scale. So for the remainder of this presentation, I wanted to look at the ways in which the care system is constructed to promote this situation. Could I have the next slide, please? There are some very obvious tensions and contradictions in NDIS policy as it relates to direct support and care workers. The dominant narratives in the NDIS design and market approach promote value for money as an important indicator of consumer choice and control. And consumer choice and control is taken as the key to person-centredness. Within these narratives, the goal for services is efficiency, and the efficient pricing model that sets funding for services is concerned only with efficiency, not quality. Quality is assumed to be determined by the market. In these narratives that underpin funding, there is very little place for skill or experienced workers. Funding is hourly and it is set at low levels, and it assumes that over 96 or 97 or something % of a worker's time is actually in providing face-to-face support, with little time for all the other things that might go to creating quality support. On the other hand, the policy narratives and arrangements for quality and safeguarding under the NDIS are much weaker than the other policy narratives. Indeed, the quality and framework was only introduced about 3 years into the rollout, so post the establishment of the market. The quality and safety framework does include mandatory practice standards and a worker screening system, but only for registered providers, and only people whose funding is managed centrally have to use registered providers. There is an NDIS code of conduct for providers and for workers, but this is framed around the assumption that workers are in organisations where they have access to good supervision and support from managers and peers, not workers who are in temporary hire agencies or engaged directly or by people they provide assistance to, or engaged through third parties, including digital platforms as self-employed contractors. Could I have the next slide, please? So in this new billable hours model that's developed under the NDIS, public sector services have been sold off, almost all of them. The majority of not-for-profits maintain still in 2019, I don't think there was a survey in 2020, that their businesses are no longer viable. The much anticipated innovation and much talked about innovation that the government has argued will occur in the new system appears to be in the growth of third-party intermediaries, including digital platforms that don't employ workers but are able to provide much cheaper services by devolving costs and risks to workers and service users. There are some examples of high-performing, flexible, autonomous teams aimed at high-quality services, but these are very much on the margins. So I think the greater innovation is in isolated gig economy care workers in informal work. Could I have the next slide, please? In the market, the new market narratives are accompanied by the traditional gendered narratives that portray paid care workers not really paid work. But these narratives are kind of strengthened. In the past they've contributed to a gendered undervaluation of this low paid work, as the work is still primarily female dominated, these narratives continue to contribute to the undervaluation of the work. However, a new narrative has come in, which is that notion of the work as informal work that's part of a sharing economy. This is really apparent in the way that the work is marketed to workers through some of the new actors, new agencies, and new like digital platforms in the market. Could I have the next slide, please? Some of the other ways in which the work is informalised in policy narratives is reflected in system design, which enables and even encourages individuals and organisations to engage workers as self-employed contractors for whom none of the minimum employment standards, including pay rates, apply. Australia doesn't have a large migrant workforce in disability support yet, but there are many vulnerable workers, including inexperienced and younger workers who are trying to get a foothold in pay work and are open to unreasonable demands and even exploitation. I've only provided one quote on the left-hand side here that really illustrates that, but this, the many quotes, workers have taken on the idea that they need to price themselves below other people to get a foothold in the market and to get a job, and they're offering their services up at levels way below the regulated award wage, minimum wages. The other really strong narrative that comes through in NDIS policy and is reflected and restated in practice in the market and taken on by workers is that choice and control is for people with disability is about being able to get the workers you want when you want them for as long as you want them to do whatever you want. And workers really kind of buy into this, apart from perhaps in the shift cancellation and getting work cancelled, as reflected in these two, in the first of the worker quotes here. And also, but more rarely, as in the second quote here, where a worker felt that she had no idea what she was doing, but that it was the person she worked for's right for her not to be trained, even though she was operating and in an emergency situation had to operate, I think it was, medical equipment, and really felt kind of out of control and that she might injure the person that she's supposed to be supporting. But she understood that her role was to kind of do what he wanted to do, be who he wanted to be, the worker that he wanted, and to just fade into the background of his day-to-day life. Now due to time, I'm relying a lot on these limited quotes to try to provide you with an idea of how the narratives in the policy are stated by the market actors and providers in the market and taken on by the workers. Could I have the next slide, please? These quotes go to these issues in traditional provider organisations, where a really common experience was of isolation and individualisation by workers who are increasingly employed in situations where their providers are employing them as on-demand workers because they don't have the funding in this regime to provide workers with ongoing jobs. The workforces are being casualised. Care workers are being engaged on much shorter shifts. Then they're no longer part of teams. They no longer have access to peer support, and they no longer have access to adequate supervision or training, which underpins good quality care and support, which they understand to underpin good quality care and support. These are just examples, but I think my research has indicated that they are actually changing the nature of care and support as it's understood And I think there is a very strong risk of Uberisation of care under the NDIS market. During the COVID, the immediate COVID lockdowns in 2020, which in my state went for almost 9 months, we were locked down. There were some really serious problems for workers who were without any organisational support, and the central NDIA agency was without the capacity to contact these workers, to engage with workers around PPE, around safe work practices, and it was all kind of left to the market to sort out. The NDIA, the central agency, eventually went to the digital platform providers who operate like a mix between Uber taxi services and dating agencies to ask them to provide a surge workforce rather than going to the traditional providers. And this has potentially, I think, undermined any industry-wide response by the traditional providers, the organisations, and also played into the notion that that disability support and care is a on-call service. And indeed, some services offer why don't you call us up today? If you forgot to get your disability worker because you forgot you're going out this afternoon, why don't you give us a call? So there is really the kind of on-demand approach to workers. Could I have the next slide, please? Sorry, so I've kind of rushed through that, but I hope I have given you a good enough sense of how I believe the system is changing, driven by the market policy and the combination of the market policy and the entry of platforms in particular to the market. Thank you.
Thank you very much, Fiona, for such a critical and timely discussion around the growing contribution of personal assistant and other informally arranged paid care workers, which is really becoming increasingly important across the globe. I would like now to introduce our second speaker, Jo Moriarty, who will be talking about career progression and a new role to support registered nurses and healthcare assistants in England. Jo Moriarty is a researcher at the National Institute for Health Research Policy Research Unit in the Health and Social Care Workforce, based at King's College London. Jo has a long-standing interest in professional qualifying and post-qualifying education and the social care workforce. She's going to talk about a study of a new role in health and social care in England. The floor is all yours, Jo, and we are very keen to hear your study.
Thank you so much for that introduction, Shereen. As Shereen said, I'm going to talk about a new role in health and social care. And it's a new role in England, but as I want to make clear, it's something that it's about an issue that affects the whole of the international workforce. Sorry, I've done that really badly because I've got in a mess. So can I just start again? Thank you so much for that introduction, Shereen. I'm going to talk about the role of nursing associates, which is a new role in health and social care in England, but that I think will become clear during the presentation and following on from Fiona's presentation, it's something that is actually an international topic of importance. So next slide, please. As I think we're all very familiar with, there are shortages of nurses throughout the globe, and obviously every country has got different strategies about dealing with the shortage of registered nurses. And this is about one of the ways in which the government in England decided to try and improve the supply of nursing of healthcare workers. Next slide, please. I think what was really clear from Fiona's presentation is how much actually most hands-on care is delivered by unregulated care workers. So if we think about England, we can see that registered nurses only make up about a quarter of the health and social care workforce, and among that we have much higher numbers of people who are working as care workers or healthcare assistants within the National Health Service and also in the largely private adult social care service. One of the things that I think is important to emphasise is the fact that I've mentioned that there were real shortages of registered nurses in the UK. If we look at the number of student nurses, there are only about 24,000 student nurses. So it means that we can't look to the role of newly qualified registered nurses as a way of dealing with shortages of nursing in England. And we have to think about different ways of supporting the unregulated care workers to become regulated professionals. Next slide, please. So one of the things that's been really echoing Fiona's presentation, we know from research that direct care workers have often had very limited access to training, and often caring isn't seen as a career, which has had consequences for its status. It's seen as a low status area of work. And so it means that the sort of idea of looking at the career progression for direct care workers to become professionals is something that's really been quite neglected. Next slide, please. And those people with long memories will remember that in the past there was a role called enrolled nurses, but that role was phased out in the 1990s because people were criticising the lack of career progression for enrolled nurses. Very few of them ever became registered nurses. There was a new role introduced in 2002, the assistant practitioner role, and that was offered some people an opportunity to move on from being a healthcare assistant to become an assistant practitioner. But obviously it was something that in terms of the numbers never really sort of took off nationally. Next slide, please. So in 2015, a report undertaken by Lord Willis said, well, what's needed is that what we really need is a bridging role between the unregulated care assistant workforce and the registered nursing workforce. And this was looking at sort of an idea about having a work-based route that would enable care workers to become professionals. And the government accepted this recommendation and said, yes, this is something that we want to see happen. So next slide, please. I think the other point that's worth mentioning is the fact that the debate between a point that's worth making in terms of how nursing operates is that there's a division between those countries, those high-income countries which only have registered nurses who are trained at graduate level, and other countries which have 2 levels, so that they have if you like, a second level nurse with 1 or 2 years of technically focused training. Next slide, please. And they're usually called things like practical nurses or vocational nurse, enrolled nurse. And basically, although these roles there are different ways of, different length of qualifying programs and different educational requirements for those who want to undertake these programs. You know, you have this division between countries which have first and second level nurses and those which only have registered nurses and the unregulated care workforce. Next slide, please. So we were asked at King's, we were asked to undertake a study which looked on behalf of the Department of Health and Social Care funded us to undertake a study looking at this new nursing associate role. And I think it's just to give you a little bit of background about that role, is that it's a 2-year level 5 qualification, which is the equivalent of a foundation degree in other, you know, in terms of comparability. It's a role in its own right. I mentioned before that in the past in England, enrolled nurses rarely became registered nurses, but this role does give people an opportunity to become a registered nurse by undertaking another additional year's training. Really importantly, thinking of Fiona's presentation about the way that much of the care workforce is unregulated, this particular role is registered with the Nursing and Midwifery Council. And in terms of sort of looking at average earnings, you know, a nursing associate would earn between 21 and £24,000 in the National Health Service, but that's in sort of putting that in context. Median earnings in England in 2020 were about 30,000. So obviously, it's not necessarily a role that's that we would say is well paid in comparison with other professions within England. Next slide, please. I also, as you're listening, you may have noticed I've only been referring to England, and it's important to make the point for an international audience that healthcare is what's called a devolved matter. And what's quite interesting is that although the nursing associate role has been developed in England, the other countries of the UK, Scotland, Wales and Northern Ireland, have so far not shown any interest in developing this role. So when I talk about nursing associates, it is a role that only applies to England. Next slide, please. There was a lot of, I mentioned the division between registered nurses and the unregulated care workforce. And you can see that when the role was first suggested, there was quite a bit of controversy within the nursing profession. So some people were very positive about the idea about developing this new role. Other people felt it would compromise patient safety because actually these nurses, a nursing associate would not be able to give the same standard of care as a registered nurse. So it was something that started with a bit of controversy. Next slide, please. So just to explain a little bit about our research, it's a multi-method study. We've done surveys, we've done case studies, we've done interviews, and what I really want to focus on. Could you put that on what do you call it? Could you put that in, Sandra? Could you put it in on big? Yeah, just want to point out that one of the things that those of us are really aware of as we have this sort of remote conference, obviously research itself has been very much affected by the coronavirus pandemic. And so one of the issues is about the fact that our original aims and methods have been affected by the fact that we haven't obviously been able to talk to patients or observe practice. So we've been very much reliant upon the views of others. And obviously what I'm going to say today, because the study's ongoing, anything I'm going to say is obviously only at a provisional level. Next slide, please. So one of the things that, just to point out that the idea of improving social mobility and widening participation was very much a role that people thought that nursing associates would be able to perform. This idea of enabling people from the unregulated care workforce to become a regulated professional was seen as something that was really important. Next slide, please. And I think could you put that on, could you zoom that in, please? To point out that some of the people we interviewed really pointed out the fact that they pointed out this contrast between the role of the enrolled nurse, which was a career cul-de-sac, and this idea about there was actually a huge appetite for learning among healthcare support workers who just wanted more development, but actually didn't have any pathways into registered nurse training, mainly because they didn't meet the educational requirements in terms of English and maths. As we know, many people who've moved into the care, who have taken up opportunities within the unregulated direct care workforce may not necessarily have had very good educational experiences at school, and that's affected the jobs that they've taken once they've left school. Next slide, please. And one of the things that we did was to do a survey of chief nurses in NHS trusts, and we found really strong support for this idea about the role. So we found that there was an idea about people were really positive about the idea about it would help deal with shortages of registered nurses because nursing associates would have the opportunity to undertake additional training to become registered nurses. It would also free up registered nurses' time because nursing associates could undertake some of the roles that registered nurses were doing at the moment. It was also seen as a way of improving retention because people would have a career to look into. And interestingly enough, very few people saw it as reducing labour costs by changing the skill mix, mainly because the earnings differential between a registered nurse and a nursing associate is actually not very large, as I'm going to talk about in a minute. Next slide, please. So one of the points that I think is really worth making here I mentioned earlier that that median earnings in the UK in 2020 were 31,000. And we know that in other countries, registered nurses earn far more than they do within England. So, for instance, a newly qualified nurse just about gets up to medium level earnings after 7 years, and a nursing associate doesn't actually reach that level. Having said that, if we look at Fiona mentioned the issue of pay and the way that the direct care workers are remunerated, and we can see that £18,000 a year is something that a healthcare support worker would earn a lot less than median earnings. So it makes it quite difficult to attract people into that role. Next slide, please. Just to make the point as well that actually nursing associates, it's still quite a small role. There's still only, because it's only been introduced in the last few years, there are fewer than 3,000 nursing associates at the moment. And that compares, obviously, if we're comparing that with over 500,000 registered nurses, that makes a huge difference. We can see that it's not going to make a huge difference in terms of workforce size at the moment, but obviously there is potential for growth there. Next slide, please. And also, I think the point that it's important to mention is this opportunity for, if we are going to try and encourage direct care workers to become health and social care professionals, we need to think about how this is going to be funded. At the moment, the vast majority of nursing associates are funded through apprenticeship schemes, which mean that most of the costs of their training are met by their employer. But there's actually a new there's an increasing number of self-funded nursing associates who will actually be funding their own higher education themselves, and they will be expected to pay. They will have to pay the usual undergraduate fees of 9,250 per year, but so we don't know at the moment whether that will. At the moment, it's hard to say whether that's going to. The self-funded route is actually going to develop extensively compared with the apprenticeship route, because obviously there are very big differences for the individual in terms of the costs that they have to pay. Next slide, please. And I think the other thing that I think sort of mentioned that at the moment, one of the advantages of taking up this apprenticeship route is that people are able, the employer pays most of the costs of learning, and so obviously it means that there isn't that sort of barrier in terms of debt aversion among people who are thinking about becoming nursing associates, as opposed to people who are considering either a direct entry route to becoming a nursing associate, or to take the registered nurse route. Next slide, please. I think although traditionally these sort of career progression routes have attracted sort of people in perhaps sort of in their 30s who have already had experience, it's important to remember that actually what people who are providing these nursing associate programs at the moment are saying is that actually they've got a huge range. They've got some people for as young as 21, and they've got other people who are perhaps much older. And so it actually, there's quite a variety among people taking the nursing associate program. And interestingly enough, consider when Shereen mentioned that her research about looking at opportunities for migrant workers, one of the things that people have suggested is that the nursing associate role can help people who perhaps have got qualifications from their own country, but they're not transferable to nursing qualifications within England. And some of those have seen the nursing associate role as a way of enhancing their own career prospects. Next slide, please. So just to finish off then, I think obviously that we're all aware, particularly those of us in countries that have been really badly affected by the pandemic, such as the UK, that there has been a huge loss of retail jobs. And so one of the things people are wondering is whether people will move from, whether this will make the health and social care sector, which is seen as more secure, look more inviting. It's important to remember as well that the National Health Service has always created employment opportunities, particularly in deprived areas, although some people say that effect has been overestimated. And then just finally, I want to sort of highlight the problems, if you like, of measuring impact of this new role when we can't do things at the moment like observations, or we can't talk to patients about their own experiences. And so very much it means that your understanding of the role is very much from the perspective of people who are employing nursing associates, and not at the other end of people who are actually using services. But we do hope in the next stages to take on the views of registered nurses and also nursing associates themselves. Next slide, please. Just before I finish, I want to acknowledge the role of people who've helped in the study advisory group, our patient involvement and engagement group, and also everybody who's ever filled in a survey or done an interview for this project, and the National and the Department of Health and Social Care for funding the research. And thank you very much. My last thanks go to you. Thank you very much for listening to this presentation.
Thank you so much, Jo, for your presentation. I think it's highlighting the much debated issue of career progression opportunities, or sometimes the lack of them completely, and in general in social care, but also in particular to newly introduced supporting roles, which is an area that requires some immediate policy attention, as you say, in response to the shortages observed not only in the UK, but in other countries. And thank you also for highlighting the difficult time we operate in as researchers with the pandemic. How is that impacting on our ability to conduct research and reach out? So thanks very much for your presentation, Jo. I'm now delighted to introduce our third and final speaker in this session, who is Professor Jill Manthorpe, who is going to present research on homelessness and dementia in the UK, the interface of housing and care services. Professor Jill Manthorpe is a professor of social work at King's College London, and she is the director of the Health and Social Care Workforce Policy Research Unit, a Department of Health and Social Care funded research unit. Please, Jill, we are very keen to listen to your presentation.
Hello, everybody. It's a great pleasure to be here, slightly in person. I wish I was in person, really, in a sunny morning in Sheffield, but we have to do what we have to do. It is a great pleasure to be able to talk to so many people around the globe about findings from a study that we recently completed. I'm going to be talking about people who are homeless, but also have dementia. It's a UK-based study, but hopefully it will have some international resonance, partly because I think there's a problem in many areas of how housing and care services work together. I conducted this study with a number of colleagues whose names will be reported at the end of the slide, but I wanted to say thanks to them and thanks also to everybody who participated in the study, which was funded by the National Institute of Health Services Research. Next slide, please. So our background to our study and the reason why we conducted it is that we knew very little about older homeless people who have memory problems in the UK. We knew that there was more known in Australia and in America, United States, but in England this was an under-researched subject. However, when talking to practitioners, they talked about a group that were often neglected and where there were many practice questions. They talked about people who had long-term alcohol misuse, untreated virus infections such as HIV sometimes, other infections, vascular disease, head and chronic brain injury, and how these were impacting upon their memory and cognition, but also on the care that these practitioners wanted to provide. Next slide, please. So in the UK, homelessness has unfortunately been a subject which has grown in importance as we have been witness to a severe rise in the number of homeless people living on the streets or living in temporary accommodation. And among those are older homeless people. When we talk about an older homeless person in the UK, we probably talk about somebody who's over 50 rather than somebody who's over 80 because of the severe risk to health that being homeless presents. It is, of course, sadly increasing in many countries, such as the UK, and we will see what COVID pandemic has done to in respect of these numbers. And the average age of death for a homeless man is 44 in the UK. For women, it's 42. And that's compared, as probably everybody knows, in a country like the UK, where the average life expectancy is 76 and 81 for the rest of the population. So our discussion of older homeless people is talking about people who are aged over 50, and many of them have many of the markers of aging very early on in their lives. Next slide, please. So our question for practice was, who cares for this population? We knew that there were likely to be many problems, that people would have many needs, and that different agencies had been involved in people's lives, either presently or previously. However, we also heard from accounts that people were sometimes unwilling to engage with care services, or they were difficult to provide services for because of their multiple health conditions, their use of alcohol, or they presented with behaviours that practitioners found challenging. Or, of course, we did hear that sometimes services were not totally willing to engage with these groups. A question for us from the care point of view is whether people had care needs and support needs that services working in the care domain could do something about and make a positive difference to their well-being. Next slide, please. We took as our population people who were living temporarily in hostels. And this slide says that once you know one hostel, because they are all very different. In the UK, a lot of them are provided by the voluntary third sector, not-for-profit sector. Some are provided by local government, and some are provided privately by people who run a business in that way. So we chose a variety of hostels for this study. Not all of them as big and as modern as that, and obviously well equipped for coping with people with some disabilities, such as having a lift. Others were based in more haphazard accommodation, in which if you had a disability, it was pretty hard to move around. So this is where our interviewers went and tried to find people to talk to and to read their case notes with permission, and to administer some tests about this problem that we were really trying to get to grips with, and that was the extent of memory problems or dementia among this population. Next slide, please. We found great variations in hostels' care for their residents. As I've said, some of them had were run very much as a bed and breakfast provision, in which there was very little contact with staff and the people living in them temporarily. Others, the staff were very much providing care. So here is a manager talking about how they manage their clients or residents' alcohol usage. and also try and avoid them spending all their money immediately in a great binge. So the manager describes that they hold on to their income from social security benefits, they hold on to their bank card, and they gave their clients a daily allowance. They do buy and give out alcohol in this hostel, which is sometimes a bit of a shock to people if alcohol is a causation of some of the problems. But what they wanted to do was to minimize the risks of major alcohol consumption, in which money would go, people would get into fights, there'd be all sorts of disruption. So they took a risk minimization approach and gave out a particularly lower alcohol form of beer or wine, gave it in stages, kept an eye, were able to monitor, and wanted people to help them move out perhaps of an acute alcohol dependency. Many feel controversial, this manager said, that we're buying the client's alcohol, but we find it reduces the risk of overuse and begging and binging as well. So here, I think it illustrates to us some of the complexities of care for this population group. When we talk about dementia, we're talking about people with a lot of care needs, and this is a particular important subset in which we must learn about the skills and experience of a workforce who don't traditionally see themselves often as part of the care workforce, but more living and working in housing services. Next slide, please. So the hostel residents recruited to the study, almost all of them had very complicated background histories. They had histories of some learning disability, often incomplete or broken education, long-term alcohol misuse, but also physical health conditions such as brain injury from perhaps accidents or in working in industries where they were common, sometimes from fights and so on. Our participants were mainly in their 50s, and for us age mattered because the older residents in particular had often lived in ordinary housing, but they'd become homeless later in life. They also drank less and were drinking slightly less strong alcohol. This means that when you talk about an older person living in a hostel, it's important to look at their background and about when they became homeless, how their lives had unfolded since that had happened, and what is their clinical history as well. And that, of course, was extraordinarily difficult for us to access because a lot of people couldn't remember where they'd been treated, what had happened to them in past years. Next slide, please. So we found, and I think this is our major finding, that nearly half of the hostel residents had memory problems, which were indicative of a form of dementia, and a further 19% of them were thought to be borderline on this scope. So if you talked about a dementia care community, you perhaps ought to include something like a hostel for homeless people, because there may well be quite high prevalence there. Those with memory problems were much younger than most people that we see in dementia services, who are often in their 80s and so on. The average age here was just over 60. And hostel staff did know this. Our study wasn't always a surprise for them. They knew where residents had memory problems. They were asking them what time was supper, how to operate the laundrette and so on. And they had very regular contact, a lot of them, with their residents. So they could often tell us whether or not people's ability to remember things on the day was linked to perhaps an overconsumption of alcohol, or perhaps was a sign that things were going bad in terms of their cognition or their memory. So quite a skilled, quite an experienced workforce. Next slide, please. And this is an example of a hostel staff member, remember, who is not nurse trained, social work trained, but seen as a housing worker, describing one of their clients. He often forgets what he needs to do, but it could be due to alcohol. He'd often ask what we've just spoken about, but he still knew when meal times were. Next slide, please. So what did people need? Some of the residents we saw living in hostels required substantial help and support to manage their everyday needs and health problems, particularly if those were compounded by memory problems. And it was hostel workers who provided the largest share of support, often beyond the traditional remit of their role and responsibilities. We found them advocating for their clients. We found them sorting out money, trying to sort out relationships. They were key workers for many of their clients and knew their clients well. Next slide, please. But there was unmet need, and I'm afraid that's probably what we will end with in reporting this study, that other services, once people were living in a hostel, thought that they were safe and being well looked after, forgetting, of course, that this isn't a person's home, it's temporary accommodation. And indeed, there's a high turnover of residents. You can't build your home in that situation, which is perhaps what you need if you're getting dementia, to have a feeling of safety and security and familiarity. And our hostel staff told us that it was difficult sometimes to get into National Health Service, NHS services, or indeed into social care services. And they said social services don't take him, the client, seriously. They're just waiting for him to get worse. And only when he'll get in a very bad way will they put him into a care home. So that was sad. And I think contrasts so much with the care that we're now trying to provide for people living with dementia. And we hope and we know that this research is fortunately being taken forward with some interventions in the London area. And so we're pleased that that has provided a baseline of information and understanding about this sector and the care that it provides. Next slide, please. This slide provides some illustrations of resources if you want to look up further material from Australia, in particular the Winteringham project, which was inspirational to our own study. And our report, published now 2 years ago, is available free in great detail online, and I've provided the link for people here. And watch this space in years to come when we will try and report back on some implementation work that's been done to change practice and to increase understanding for this difficult group. Or not difficult group, a group that it's hard to help, but I'm sure that everybody will agree really needs help and needs to be brought more into the spotlight in terms of care. Next slide, please. Here is on my acknowledgement side, thanking everybody who took part, and particularly thanking our funders for keeping this study going. It was not easy to do, and we are very grateful to our funders for acknowledging the difficulties of reaching this very hard to listen to group and hard to reach physically in many circumstances. So thank you for listening. I hope you've enjoyed this brief overview of a study, and I'd be delighted to hear from people by email or so on if anybody would like further information about the study and its findings. Thank you.
Thank you so much, Jill, for your interesting presentation. Focus on a group that is usually marginalized and not well researched. So it was very good to listen and hear about your research in this area. I would like now to introduce our discussant for this session, Dr. Agnes Turnpenny. Dr. Agnes Turnpenny is a researcher at the Persons Social Service Research Unit at the University of Kent in the UK. Agnes has a background in social policy, and her research interests include social care workforce, services, and comparative policy research. Thank you for joining us, Agnes.
Thank you very much, and thank you very much for the very interesting presentations. I really enjoyed them, and so I would like to highlight a few key points or threads that were important or came out to me, and perhaps and offer a few questions that perhaps we can discuss further. So the presentations today highlighted the huge diversity of the long-term care workforce in terms of roles, qualifications, and settings where people work, and this is across the globe, so not just a national issue. Also, we also see an increasing complexity of jobs as they more and more involve tasks that just go beyond the tasks of assisting daily living and include, for example, implementing complex care plans, working closely with healthcare professionals, and even some simple or basic clinical tasks. And this is perhaps is a response to the increasingly diverse and complex needs of the people who use long-term care services. But this complexity and of the roles often goes unrecognized in long-term care systems. The presentations we heard, to me, kind of highlight two key dimensions of the long-term care jobs. One goes in the formal, informal kind of spectrum, and the other one from the precarity to secure jobs. So, and we see a growth in kind of both quadrants, partly driven by the marketization and personalization agenda on the informal precarious quadrant, and the increasing drive towards integration with healthcare, at least what we see in the UK, in the kind of more formalized and secure employment. So Fiona's presentation looked at the kind of informal and precarious part of this of the matrix, and yeah, in the sorry. So Fiona's presentation looked at the informal and precarious workforce of personal assistants in Australia's NDIS system, and I really found fascinating your discussion of the emerging gig economy of care workers, especially the slide where you showed the two adverts from platforms and job sites for the people, that to me really just highlighted how the exploitative nature of the gig economy meets this kind of really gendered nature of care work. And also I really found your reflections on the empowered customers very, very interesting. So here are just a few questions as I was listening and reading your presentation. What do you think? Is there an inherent tension or contradiction perhaps between cash for care and kind of self-directed support systems and the kind of individualization, isolation of the workforce? Is it possible to kind of create a secure and formalized workforce in cash for care systems, and which way we could go about this? And yeah, so, and do these cash for care systems necessarily need to result in a gig economy in the age of platforms? So is there a way to avoid them or perhaps regulate them? And also I would be, you briefly touched upon this, but I would really like to hear perhaps more on what drives personal assistants into these jobs, but also if you have any information, what drives people who use services towards these more unregulated PA market, rather than trying to source services from more formalized providers. Yes, and also, it would be really great to talk about the alternatives, because is how people with disabilities can keep their not hard-fought independence, or at least the illusion of independence, in that they fought so hard in the disability rights movement, but still kind of make sure that workers' rights are respected, and there is a more secure and stable workforce. So how can we go about this? And also I would really like to discuss further the impact of this professionalization on customers. So do these systems co-opt them into being their own managers? And does everybody want this really? Or is this perceived as a burden, especially from our own research with informal carers supporting people to manage personal budgets in England? We found that this can be very, very burdensome, and this is outsourced by local authorities onto them. And now coming to Joe's presentation about nursing associates, who are kind of the opposite quadrant, at least for now, they are formal and relatively secure workforce, or at least secure jobs, especially those that are part of the National Health Service in England. And this is the group I feel that are at the interface of health and long-term care, and this is very much talked about at the moment in England. I really enjoyed the depth of your presentation, and it will be very interesting to see more findings as the study progresses, especially if COVID restrictions are lifted and you can carry on with your field work. So maybe perhaps if you could tell us a little bit more about your plans, your next steps. And also I'd be really interested to hear about what you think, or how you see the future of this role, and how we all see the future of this role. The graphs on slide 15 that compare the reasons for the introduction of the nursing associate roles, the chief nurses, and it really struck me how reducing labour costs was not seen as important, at least at these early stages. But do you think this might change in the future? Is there a risk of creating like a two-tier nursing workforce in the NHS? Especially what you said about from the interviews about migrants whose qualifications might not be recognized, or other people who can't perhaps afford to go to university. Is there a risk of creating perverse outcomes? And rather than this becoming a bridging role, might kind of filter or trap people into this kind of second tier nursing associate roles that are no doubt going to be worse paid and less secure, or offer fewer career progression alternatives. Also, I'd be really interested to discuss how you see perhaps the link or the lessons of the nursing associate roles to the broader social care workforce. Could this be like a model that offers people who work in adult social care some sort of career progression that is much talked about it, or is this perhaps can be a way for the much talked about kind of parity between adult social care workforce and NHS workers? So, yeah, thank you very much.
Thank you very much, Agnes, for some very interesting questions and discussions about these two important topics. I would like now to open the floor and invite our speakers, Dr. Fiona Macdonald and Joe Moriarty, to join us in our question and answers session. Unfortunately, Professor Jill Manthorpe was not able to join us in this session, but I'm sure we're going to have such a stimulating conversation about these very timely topics. So I would first perhaps invite Fiona to respond to Agnes's reflections before we move on to Joe's response, and then we can have some discussion as a group. Fiona, please.
Thanks, Shereen, and thank you, Agnes. Some great questions there, and thank you very much, Joe. I wanted to kind of engage with you point by point. Thank you. It was before I address Agnes's questions. It's really interesting, Joe, because I don't think what I made clear in my presentation is that in the area of disability support and care in Australia, we had the basis for career progression for those lower paid care workers who in many systems are just like kind of stuck there at the bottom, low paid, assumed to be unskilled. We actually had the mechanisms. We didn't have them in aged care, and in healthcare we do have that division between low skilled personal care and support workers and nurses. We do have a state enrolled nurse occupation, but healthcare is not my area, and our health and social care is not integrated in Australia. But what we did have in disability support and care and in home care, we have the mechanisms. We have our industrial relations system had a system of awards-based, industry-based, occupation-based industrial standards that are linked to skills. And so it didn't, it was pretty dead end, to be honest, for home care workers. We have a separation between aged care home care workers and disability support workers. But for disability support workers, there was a clear career path and progression path. There was a clear recognition that there are a range of skills required in the role of personal support and care, and we've completely undone that with our new individualised or personalised care system, which is quite distressing. I'm not saying that it functioned perfectly beforehand, but it's now kind of been undone by the decollectivisation of workers that I was talking about, by funding levels that basically only fund at the bottom level. So if I'm an employer and I've got and this is, employers, providers that I've spoken to and worked with, I've got an experienced workforce who are able to respond to complex needs. I can no longer employ them in the way, because it's an hourly based kind of billable hours regime where if they're employed to provide they're employed under this new scheme where they're funded to provide support at a higher level. But say, for example, that person is ill for 2 weeks or hospitalised. As an employer, I can't pay them. I can't redeploy them to support somebody with needs that have been assessed at lower level, because I'm not funded to continue to pay them at the same level. So I revert to employing casuals. So the whole, that's one example, but the whole system's kind of designed in a way that undoes that opportunity for pathways. Agnes, I think what are the answers? I think a regulation actually is needed in relation we don't have, and I know you have a slightly better but also problematic regulation in industrial relations in the UK, where somebody who provides personal services as a contractor may not be an employee, but they're not assumed to be an independent business and have no employment rights. We have the binary: you're either an employee or you're an independent contractor, and therefore you've got no employment rights. That's a really big and broader economy issue. We need to deal with the independent contracting problem, and it could be dealt with within the care policy by saying that, if you are a direct care worker, you must be deemed to be an employee. We could have that. We've just been having that debate in a Royal Commission around our aged care arrangements. Can a home care worker be an independent contractor? Should there be an employee? So that in the industrial relations sphere, there's lots to deal with, but I think it's also what we say about how it's within the capacity of the care system to address that as well. Why do people use platforms, and why do workers go to platforms? Workers go to platforms because there are two. I think it's there's not much research, but my growing impression from the emerging evidence that I've got interviewing workers, there's two levels of workers who are highly skilled and experienced, and they can decide who they work for and with, and they can do that because they've benefited from the training and skills that they've developed with organisations that provided care. They're attractive, they can command good wages. Other people, they're just looking for work. And all of a sudden, this is, you could put your name down as, and I'm being a bit facetious here, but we have a digital platform where you can put down your name to go around to people's houses and, I don't know, put their IKEA furniture together or mow their lawns or whatever. It's like that. It's being viewed like that as a consumer service. Why do service users use these services? Because it's very unregulated. You get a lump of money, and if you can get more hours for your money, I get 1 hour of disability support, but I want very different things done. So what I start doing is tailorizing it, breaking it up. I'll get someone to come around and clean this, and I'll get somebody else to come around and do this. I'll get someone around to mind the cat. And people are doing that because it's not actually, for many people, a generous system. It doesn't provide enough hours of support. Alternatives, I think, are we need umbrella industry bodies. You can have all sorts of arrangements whereby workers are connected to organisations that take responsibility or are accountable for their employment conditions, and putting together a package of work, whether it's a job or different work, and B, their longer-term career and the quality and safety of support they're providing. So it's that umbrella-type organisations. We used to have organisations in Australia called group training companies that managed apprentices because in recognition of that small businesses don't necessarily have the capacity to offer a full 4-year apprenticeship to somebody. So the apprentice became an employee of the group training company, and they were sent out. So like a kind of labour hire or agency model, but with responsibility for the worker, the quality of the work that they perform, and their training and their employment conditions. Impacts on consumers. I think if you're very well, it's the increasing inequity thing. If you're able to, if you've got extra resources, if you've got, whether those are educational resources, all sorts of personal resources, financial resources, you can manage this really well. Other people are just trying to get more for their money. Sorry, Shereen, I hope I didn't take too long. I wasn't kind of...
No, thanks. It's really interesting, and it resonates. It's really interesting what you said about the almost 180-degree switch from having a clear pathway to protection and progression, which is something actually we lack here in the UK, and it's quite patchy, to an idea that it's got the triangle between efficiency, empowerment, and choice, but then versus quality, protection, and increasing gig economy, which is really something that we all need to look into, because it's happening at different degrees in different countries. And as you say, aged care might be different from a disability services because of the NEDIS. But this is something I would like to ask you a little bit more, perhaps after we hear Joe's reflection on Agnes' kind of point. And then I can see a lot of commonalities that we can then draw in from the experience of England and Australia, which from our own research internationally, we know that it actually resonates with many countries, not only more developed countries, but it's the whole gig economy around care is across the globe, and happening even in less economically well countries. So Joe, without any further ado, it would be really interesting to hear your reflections on Agnes's point.
Thanks very much for that, Shereen. I hope I'm just going to warn you to say that I've just had a message about a parcel. So if suddenly there's a bang and I have to run away, then I will be back in 1 second. It's bound to come. The whole of the day, it decides to come during this session. doesn't it? But anyway, and I've also a bit worried that because I wasn't sensible enough to start off with a pen so that I could write down all the points Agnes made, I might have missed something. So you might need to recap it a bit, Agnes. But first of all, to sort of deal with that sort of very practical point about labour costs, at the moment, because the proportion of nursing associates is so small in relation to the number of registered nurses, we wouldn't really expect to see a reduction in labour costs by employing nursing associates rather than registered nurses at this stage. But obviously that's something that could change if the numbers become much larger and the proportion, they become much more even in terms of the division between registered nurses and nursing associates. I think the point that you made about career progression in adult social care is really important, because one of the things that we know from the way that nursing associates have developed so far is that although it was a role that's meant to span health and social care, there's been much more, many more of them are employed in the National Health Service, and the many more NHS employers have actually sponsored nursing associates. So at the moment, there are far fewer social care nursing associates, trainee nursing associates, or qualified nursing associates working in social care. But some social care employers have made the effort to, have and I'm going to start that sounds awful, made the effort sound negative. One of the problems in terms of expanding the role in social care is that we all know that there's a huge difference between employers in terms of their commitment to training, and some employers are really good and really develop their staff in terms of continuing professional development, and other employers really neglect this topic, and staff are left to sort of carry out care work with very little training whatsoever. And this is reflected, I think, in the number of employers that have looked to develop the nursing associate role, which at the moment there are far fewer of them than there are in the NHS. But there are some, and one of the points that people have been making to me in terms of interviews is that nursing associates spend, although they're on the apprenticeship route, although they spend 80% of their time is with their employer, but 1 day a week is in college. But when they have to go on placements, some of them are going on placements in social care, and it may be that they have that experience in social care, and when they qualify, they think, actually, I will take a job in social care. Because where people think that the role will expand is in particularly in care homes with nursing, where obviously we know from the research about the characteristics of residents, that residents in care homes with nursing are becoming progressively frailer and iller and with more complex medical conditions. So there's definitely a role for them there. And then finally, that point that you made about will we end up with a two-tier system? That obviously is a real risk, but that depends very much upon the number of nursing associates who are given the opportunity to take up that opportunity to become a registered nurse, and also in terms of the way they're viewed within their work environment. So you mentioned particularly that issue about somebody who came from another country, who had a qualification from that country. Now, if they're working in an area where there is racism and where they are devalued, obviously becoming a nursing associate isn't necessarily going to change the status. But if you're talking about environments in which people feel respected and which they've got a clear role and they can see that they're valued, then that will definitely avoid the risk of it becoming a two-tier system, because people will see it as a role in itself and something that can be, something that can perform a valuable function. So I, for instance, spoke to somebody who I was quite surprised about this, but he was talking about nursing associates during working in intensive care units during the pandemic, and how that had been people have been really grateful for the role and really sort of saw it as something really valuable. So that would, if you like, that's the positive side of it. But we don't know yet whether that negative side, which perhaps, replicates that idea that we have from other countries, where the second level nursing qualifications, people with second level nursing qualifications, people who are seen as practical nurses, don't get that opportunity to become registered nurses.
Thanks, Joe. It's a very important topic, and obviously, I'm sure in other international settings that has been happening. But even in the UK, we've had before the care certificate as something that it was upskill care workers and links between the NHS and the social care, and it had its own challenges in practical kind of applications rather than in the concept. So on that note of really career progression, I would like to turn back to Fiona and reflect on something she said, and particularly around this. It seems that Australia, particularly within the disability service, moving into this gig economy and the de-appreciation of skills, and also moving the control and access to skills to the employer, who has become the budget holder. And you did provide an example where actually workers felt that they need training for the safety of the service user they're caring for. However, perhaps the service user didn't feel the need for that training. So can you elaborate on this and how, maybe on the risks that creates that the system and the policy is designed with less important outcomes, I would say, which is efficiency and cost reduction, perhaps guised more under the hat of empowering and choice, but actually overseeing and neglecting some really important issues that are essential for the safety and quality. So if you can reflect on that, that would be great. And similar question would be to the idea of personal kind of upskilling personal health assistants. But let's focus on the case of Australia and maybe reflect, Fiona, on the differences between aged care and disability care, because not a lot of the audience would be aware of how different this is in Australia. So in England, we have that like an umbrella of social care, which is the difference only of younger people, perhaps under 18, rather than disability or an older person.
Okay, thanks, Shereen. Probably if I go to the last issue first, it's helpful to kind of give context. The aged care system and the disability care and support system are quite separate, but what is not separate is the home care for the aged is in this kind of same basket as disability care and support, which is really interesting because it kind of goes to the value of the work, I think. And then, the home care, it's if you put the kind of acknowledgement of skill and pay on a sliding scale, the location of work in the home, the location of work in the care home kind of corresponds to how much it's valued. If it's in an institution, it's historically been better valued and better paid, and skills have been recognised. So while the two systems are quite separate, home care workers are under kind of different arrangements from residential aged care workers. And what we're seeing with the NDIS is disability support workers who were considered and classified industrially in the employment system as community development workers are now being recast as home care workers, because home care workers don't have the same kind of skills pathway or pay. So, first of all, we had the aged care workers, separated out because they're in the home, and even within that broader community space, they're separated out from the other workers. So, the valuing, I think it goes to the point I'm trying to make, I think, is it goes to the kind of historical gendered undervaluing of the work, and the ways in which that plays out in our structures and systems for providing opportunities for the workers with pathways now. And those historical divisions are being exploited in the unregulated system we've got now. So there's this kind of pushing down of workers into this space where they're considered unskilled. Now, I think underlying some of the issues here are the notion that empowerment is achieved through direct engagement and through lack of, through no regulation. It's a kind of really narrow view that's played out in the policy and that's being played out in the market of what empowerment for people with disability in their engagement and use of services might mean. It's a very immature kind of framing of it, immature in the sense of simplified, perhaps, and also, it's very accepting of the idea, which I think is only held by, some groups of people with disability, that empowerment has to be power as an employer. It's kind of accepting that, and it's not working. For many people with disability, this new system, they don't get the support they get. They are all of a sudden managers of their own care and support, and they're dealing with bureaucratic systems. It really, I referred before to the creation of inequity. A paper by a colleague, Amaya Alvarez, has presented earlier at this conference, really dealt with that. She looked at mental health carers, informal carers, and what's happening to them under the NDIS, and they're just facing a massively magnified workload. In relation to what you might do, I think there have been some proposals in Australia. For example, individual budget holders are not, aren't going to pay for somebody to do intensive or lengthy training, or training that they don't understand themselves. How are they supposed to be experts on what training might be useful? There have been some proposals put forward for a training guarantee, or like a portable training entitlement. So if you're a worker in the system, for every hour that you work, you bank an entitlement to some training. So it doesn't matter who you work for. It doesn't, if you're not connected to, you're only providing 3 hours support and care here for one individual and 5 hours somewhere else. You still have this entitlement to care and support training. So it's going back to what I was, talking about before, in a more abstract kind of sense of connecting people back to a bigger system. So providing people with a training entitlement that is also linked, building back into the pricing structure, that if you develop skills that, you were used to have, if you have a certificate, then you have an increment in your pay. So I think that's possibly really one partial solution. Yeah. Mm-hmm.
Yeah, it's really interesting that it's really going back full circle. So it's you had a system which have all these embedded kind of pathways and protection, and it's the push, from my point of view, to this efficiency, which is productivity or basically low cost, that creates a new policy dynamics that guises under it might have a real goal, a true goal of empowerment. So obviously there is kind of a true impact. However, it has been overplayed and not really examined well to see the implications on both the service users, their family, because they will, shoulder a lot what we're seeing in a lot of research, that actually the family becomes the care coordinator, becomes a supervisor, and take on much more bigger roles. And for example, while here in England, when you have a personal budget, the local authorities still hold responsibilities for overseeing and coordinating this. However, there are options that you take this as cash and you don't have a coordination, although that is much lower now. But what we're seeing actually a growth in the what we call informal arrangements around live-in carers. So particularly because the system here in the UK and in England particularly is means tested. So both needs and means tested. So not everybody with needs will get any funding, state funding. So it becomes a private arrangement, and it's regressing back to models where there are no clear regulations or pathways, and it becomes a very private arrangement and a mixture of, as you say, you break down your needs into a bit of cleaning, a bit of walking together, a bit of companionship, and a bit of personal care. And this is quite I don't want to sound pessimistic, but it is a dangerous territory. So it is quite interesting to see that there is a scope for empowering people and having individual choices, but again, without overseeing the training needs. As you say, a person receiving the care, if I go to the doctor, I don't know which specialist I need to be seen by. I have no clue. And it's similar. If I need someone to look after me in a certain way, they need to have training in handling and safety in giving medications. I wouldn't necessarily know which training they need to go to. So it's good to see that there are efforts that is happening, and also this collective voice. So I think there is a room for unions, for example, and empowering workers themselves. So it's going back and linking to Joe's presentation, really, I was really interested. I was thinking about, what you were talking about. And it's not the first time, as we said, that this is something, kind of a training or a skill certificate being introduced with the hope to achieve certain goals. And the new roles that introduced, from my point of view, have a desired outcome, two main outcomes. One, it is an upskilling opportunity. So you have to, we also have said that the social care sector is rather flat hierarchy, but even if we're talking in the NHS context, perhaps if you don't have the nursing qualification, you stay in this flat hierarchy. So this is maybe a way to, upskill. But then the question remains, does it really achieve that? Does it really create a better working conditions and further opportunity pathways of further progression? Or would it, as Agnes was saying, perhaps create a two-tier system and more perhaps prejudice? And the other point or desired goal is this substitution. So you started by saying that we can't train more than X number because basically there are lots of factors coming in play here, including demographics that people have to, which groups goes to nursing training, how many, the ability of higher education's capacity, etc., etc. So there is within this policy a thinking of, okay, there are people already working on the sector, might be attracted at lower grades, might not be able to put in all that time and money to get qualified in nursing. So that's a kind of substitution. And here again, the question would be, what are the implications? What did we do this, and did we do it? In compromise something else? So how about this? You started by saying it was controversial around safety, patient safety, quality of care, and linked to that is this, because it's the employer, the cost will be on the employer to offer the training. Have you seen any inequalities in the choices of who would go forward to these trainings? So I'm sorry, it's a much loaded double questions, but I think just reflecting on this would be really useful for the discussion.
Okay, thanks very much, Shereen. I think to start off with that last point, first of all, the one about do we know about inequalities in terms of who takes up these roles, and are there people who are excluded from them? We don't know yet. In terms of sort of issues about age and diversity, just because there are comparatively few sources of information that look at all the nursing associates, but that would be something that is really important to look at, because obviously we would assume there will be many more women than men, just because that's what the wider care workforce reflects. But we don't know about things like ethnicity, and we don't know about things like citizenship status in terms of people given that opportunity. But that is, I think, something that is really important. I think the controversy stems from the fact that one of the people, there were people who felt that the move to degree level status for nursing was a very important decision for them. And they saw, the people who were critical of the role saw it as diluting that idea that to become a registered nurse, you would do a degree level qualification and you wouldn't be a sort of an employee, you would be in higher education, and 50% of your time would be on classroom-based learning, and 50% would be on practice placements. But it's hard to say at the moment, because obviously the people who we've spoken to, the people who have filled in surveys, the people we've interviewed, are probably, some of them will be people who were really committed to the role, who were involved in developing it. And the people who, one of the difficulties from a methodological point of view is that I spoke to somebody who wasn't directly involved in developing nursing associate routes, but so they don't always have that knowledge about what it's meant to be and everything. And it's really hard to see whether it feels as if it's a role that's become more accepted and the controversy seems to have died away. But that might not be true a couple of years down the line. So it is, I'm sort of being a bit sort of, well, we'll have to wait and see. But I think the points you've made there are ones that will need to be answered, once at the end of the evaluation.
Thank you so much, Joe and Fiona. I think we can go on discussing these issues really forever, and they are really important at these times where across the globe I'm doing a lot of work in low and middle income countries, and even there the people are discussing aging populations and the need for formalizing the care workforce and long-term care and models, and they're looking at countries like the UK and Australia to see what they're doing. And obviously the same countries have been trying different ways and going a little bit in different directions, which is quite interesting. And I see that there is cross-learning. So there is a lot of learning that actually could be done, not only north-south, but south-north as well. So it has been a very interesting session. I'm very grateful to all your inputs. The presentations have been very interesting and thought-provoking. Thanks, Agnes, for a very interesting discussion. And thanks, Jill, for her earlier presentation. And thanks, everybody, for listening and tuning in to the conference. And I wish you enjoy it and enjoy other sessions in the conference. Thank you, everyone.